Good morning, good afternoon, good evening, everyone. My name is Pei-Shan Liu Snyder, and I will be the moderator for the following 3 conferences with our special guests. Thank all of you for being here with us today. We hope that you and your family are safe during this uncertain times in the middle of COVID-19 pandemic. On behalf of International Society of Pharmacovigilance, ISOP, we are very pleased to welcome all of you to the ISOP Patient Safety Day events that are held today. The COVID-19 pandemic has unveiled a huge challenges and the risk that healthcare workers are facing globally. Therefore, the ISOP engagement is to develop and share those safety awareness sessions to different audience, patients, caregivers, and healthcare professionals, with the aim to increase safe use of medications and avoid medication errors around the world. Now it's my pleasure to introduce our President, Mira Harrison. Let's hear a few words from her.
Patient Safety Day. Hello, welcome to this ISOP webinar on World Patient Safety Day. My name is Dr. Mira Harrison-Woolrich and I'm the President of ISOP. Thank you for joining us for this series of very interesting events to discuss what ISOP and our colleagues around the world are doing to focus on this very important day. World Patient Safety Day began in May 2019 at the World Health Assembly. All WHO member states endorsed the establishment of this day to be marked annually on the 17th of September every year. The reasons for this were quite outstandingly clear. If you look at these statistics that I've placed on the screen, there are many things that we really do need to address in pharmacovigilance. For example, 134 million adverse events occur every year in patients in low and middle income countries. 2.6 million deaths annually are due to adverse events. 15% of hospital expenses in OECD countries are due to treating patient safety failures. 4 out of every 10 patients are harmed in the community setting worldwide. So this issue, which is not just restricted to adverse events associated with medicines, but more generally to patient harm, it's not just restricted to hospitals, but also to community settings around the world. The aims of World Patient Safety Day are to recognise patient safety as a global health priority, to increase public awareness and engagement, to enhance global understanding of patient safety, and importantly, to spur global solidarity and action to promote patient safety. All of these aims, which were derived by the World Health Organization, align strongly with the missions of our society, the International Society of Pharmacovigilance, which is to protect patients from harm by promoting the safe use of medicinal products worldwide. I'd like to just tell you a little bit about ISOP because I realise that many of you tuning in today will not necessarily be members because we have opened up these events to everybody for free of charge. But our society, in summary, is an international non-profit making professional organisation aiming to promote drug safety scientifically, clinically and educationally in order to enhance all aspects of the safe and proper use of medicinal products. In this definition, we include all drugs, vaccines and medical devices. And I should say that includes drugs which are sold over the counter and herbal medicines as well. And we aim to cover all countries. We currently have approximately 800 members in approximately 100 countries worldwide. We have regional chapters in Africa, Asia, Europe, Latin America, Middle East, USA and Western Pacific. We also have a number of very active special interest groups. These webinars are being produced by our medication error special interest group, and we have other groups that discuss herbal medicines and women's medicines. So if you are interested in joining ISOP, there's plenty of ways in which you can contribute to drug safety by being involved in these regional chapters or being involved in the ISOP special interest groups. Do have a look at our international website, which is on the screen now, isoponline.org, and look at the membership page and do think about applying if you're not already a member. So I'd like to move now to how can we work together this year, 2020, to reduce harm to patients worldwide. It's a very important year in medicine safety with the current pandemic crossing our world. And then maybe the first thing to say is what we're all already doing here at this meeting is participate in these World Patient Safety Day events to start to learn what's happening worldwide in your country, in your region, and across the globe. So let's try to become educated, first of all, on all the key issues affecting patient safety in our countries. For example, are there issues with access to safe and effective medicines? Are there issues with medication errors, prescribing issues, or compliance issues? Or are there, and this could apply equally, special and specific safety issues with particular medicines, devices, or vaccines? The next thing we can do is to remember to report suspected adverse drug reactions to all medicines, devices, and vaccines. In most countries, there's a national authority where you can report any adverse event, and this information is available online. As I was saying earlier, this year is a very important year because of the pandemic and issues with vaccine safety and medicine safety. So think about joining a professional society such as ISOP to collaborate and share information with your colleagues. And the next and perhaps the most important thing I have to say about this is to start some conversations about pharmacovigilance, about medicine safety in your pharmacy or your clinic. I'd like to just share with you now one example of what ISOP has been doing to start these conversations about medicine safety. Throughout this year, we've developed the image which is on your screen now, which is an infographic about using medicine safely during the COVID pandemic. This was developed by a group of us within the International Society of Pharmacovigilance, and we wanted to try to communicate 4 key messages about using drugs and other medicines at this time. And you'll see on your screen there are 4 areas that we have focused on about where you access medicines from, how to act on side effects of medicines, how to stay safe and healthy. This is a really important point because a lot of people actually start using medicines differently in times of crisis and pandemic. And lastly, being aware of fake news, of wrong information, and directing people to information sites which can be reliable and can be trusted. We also developed this infographic in several different languages, and I will just show you some of these now because we are aware in our society, although English is the official language of ISOP, many of our members around the world, of course, speak different languages. So I'm just showing you now on your screen the infographic in different languages. And these are all available on our website, on the ISOP website, which is now on your screen, and they also can be found on our social media platforms. Please do take a moment to have a look at them. Feel free to download them, print them out, and use them wherever you can to promote patient safety in your country. So just to wrap up this introduction, as the webinars commence, please think about the following things. This day, World Patient Safety Day, is a really important reminder to all of us of the need for continuing work on protecting patients from harm in all countries, wherever you work. Do enjoy and learn from the presentations by the ISOP speakers and by our international collaborators during the series of webinars. The WHO estimate that up to 80% of harm to patients can be avoided. That's such an important statistic because it means there is a lot of things that we can do. So implement what you've learned in these seminars, take them back to your country and implement them in your healthcare community. And again, please consider joining ISOP, and we'd love to have you join us in our society and become engaged in all the activities that we have to offer. And the last thing to say before we start the programme of events is please remember that every day should be patient World Patient Safety Day. Thank you for your time, and thank you for listening, and I do hope you enjoy the remainder of the events.
Thank you for your attention. Now let me introduce you to our first speaker, Dr. Michael Cohen. Michael Cohen is the president and the founder of the Institute for Safe Medication Practice, ISMP, a nonprofit healthcare organization that specializes in understanding the causes of medication errors, providing error reduction strategies to the healthcare community, policymakers, and the public. He is the chairperson of the International Medication Safety Network. He has served terms on the US FDA Drug Safety and the Risk Management Advisory Committee and the Non-Prescription Drugs Advisory Committee. He is a current member of the Expert Committee on Labeling and Nomenclature for the United States Pharmacopoeia, as well as a consultant to the FDA. Today, he will give a presentation on working together toward the global progress in prevention of harmful medication errors. We invite you to actively participate during this presentation. So if you have any questions, please enter them in the chat box. We'll respond to as many as we can during this session. The rest of the questions will be answered and published in our Q&A section of Patient Safety Day on our webpage, isoponline.org. Without further ado, please give a warm welcome to Dr. Michael Cohen. I'm handing the meeting over to you, Dr. Cohen.
Okay, thank you very much. Are you able to see my slides?
Yes.
Okay, great. So good morning, everybody, and good afternoon and evening and night. As we heard already, we're calling in from the East Coast of the United States. I really would like to thank ISOP for inviting us to participate. I'm honored to do that for World Patient Safety Day. I actually represent two groups. ISMP, or Institute for Safe Medication Practices, is a nonprofit organization. And I also represent the International Medication Safety Network, which is a group of safe practice centers like ours, but also we have members from the pharmacovigilance community. Some of the centers are members. Also, we have a number of regulators, including the US FDA, Health Canada, EMA, and several others. And we meet every year and share information. And about a year and a half ago, we began to interact with ISOP. And last year, we had our annual meeting in Rabat, Morocco, at the Poison Center there. And we also began to interact with the Uppsala Monitoring Center. And our focus has been totally on medication error prevention. And I know that that is of great interest to the PV centers around the world and to those of you that work in industry in the area of pharmacovigilance. So I really did want to share information about our program and the model that we've used, because it really relates to, first of all, tapping into the direct input from healthcare practitioners, providers, those that are out there working in the pharmacies, in the nursing homes, on the hospital wards, in the emergency rooms, and so on and so forth. They want to tell you their story. It doesn't necessarily mean that they have a way to do that. We actually started something back in the 1970s. I happened to be a pharmacist that worked in a university hospital in Philadelphia. I had the great opportunity of being one of the first clinical pharmacists. So I worked on a 56-bed men's surgical ward soon after I left the School of Pharmacy. And we learned a lot, and I saw a lot. I was working with the doctors and nurses every day in the unit, and my pharmacy was just outside the unit. And we had a great relationship, and I started to see things that were going wrong. And as a pharmacist, obviously, we're certainly concerned about medication safety. And so I thought I'd look more into that than I had in the past. And one of the first reports that we found very interesting was a very simple thing. The abbreviation with the letter U for the word units. Unfortunately, when it was handwritten, and we obviously didn't have electronic in those days, it looked like a zero. and we actually had 40 units of insulin administered to a patient instead of 4 units of insulin. That happened again and again, in other areas of the hospital that I heard about. And then there was a newspaper article on the right there, you can see it on my screen, where somebody actually died from this overdose. And then we learned of other reports. Just the simple thing of writing the word units out would prevent this from happening. And so we decided to start a column in one of the pharmacy journals and invite pharmacists and later nurses from around the country to contribute actual reports of medication errors that they were aware of. And even more important, near misses or hazardous conditions where they were very concerned about something that might lead to a serious medication error. And that is how we got started. It started as a journal column. Then in the 1980s, we started seeing some other things that we thought we could do something about. For example, potassium chloride concentrate. We had problems, I think you can see from the picture there in the middle of this slide, with look-alike containers of concentrated potassium chloride that nurses would use to add to an IV bag being mixed up with sterile water. We learned about cases that happen outside the United States where it was mixed up with saline, for example. We then went to FDA and we began to interact with them, and also the United States Pharmacopoeia, and they came up with some prevention recommendations. I think you can see what I'm getting at. We are now talking to not only the providers, but also our Food and Drug Administration, also the United States Pharmacopoeia, which is a standards organization and can have the force of law. And FDA, in almost all cases, would have to follow their recommendations. In this particular case, they put a black cap on it that says must be diluted. They changed the name, they put a red label on it. It may have helped, but what really helped was when we started pushing the practitioners to remove concentrated potassium chloride from the nursing units. And at that time, we started to see pre-mixed fluids with potassium already in it. So it was something that we were able to do in the United States. And I have to tell you, the Joint Commission, another player, obviously, a standards organization, but also an accreditor, and they are worldwide, they told hospitals that they could no longer keep concentrated electrolytes like KCl on the nursing unit. So again, I think you can see what I'm getting at. It really takes everyone's actions, not just ISMP, not just the FDA. We really need to be working together. And that is truly what we hope to do through IMSN and through ISMP. We have ISMP in Spain, we have ISMP in Canada, we have ISMP in Brazil. And furthermore, we're affiliated with another company, a nonprofit called ECRI, ECRI, and they have locations throughout the world as well, in Malaysia, in Dubai, and in England, in London. So these are all things that we started to learn about early on, and we started to publicize. And here was another one. And this, by the way, the potassium happened 3 times that I know of outside the United States last year. All of them were fatal. So I realized the PV centers wouldn't be the ones that would publicize removing it from patient care areas, but the regulators could do that. I don't see a problem with information like that going out to the field, and I certainly don't see any accreditation organization being prevented from pushing for safer potassium chloride, and I don't see any problem with the industry making more fluids available at reasonable cost that already have the potassium in it, so that the nurses don't have to manufacture the drugs on the floor, reconstitute on the floor.
Dr. Cohen, sorry to interrupt. Can you switch to the presentation mode?
Oh, sure. I'm sorry.
Yeah, no worry.
There you go. Okay. Do you see that in presentation mode now?
Yep, it is.
Okay, great. So I wanted to tell you about this. This is drug vincristine, which we're all very familiar with, used in acute leukemias, and it is only given intravenously. However, we have over 140 cases that were reported, all of them fatal, where it was given inadvertently instead of methotrexate, which is a spinal drug for leukemic patients. It's given into the central nervous system, but this drug, if given intraspinally or intrathecally, winds up killing the patient. So a simple thing like putting it in an IV bag and preventing syringe administration totally, all of the 140 cases were syringes. This is something that should be promoted worldwide. In the United States, our Food and Drug Administration this year changed the official labeling of the product. It is no longer administered in syringes. It is only for dilution in a mini bag, which would never be used along with a syringe of methotrexate, when a lumbar puncture is done to treat a patient with acute leukemia. So this is a really important thing to learn about as well. Our FDA and other regulators have looked at other safety problems and changed labeling that has come from reported problems from the practitioners directly, not necessarily the industry reports. We serve as an early warning system. We disseminate the information through multiple newsletters that we have that reach community pharmacy, nursing, long-term care facilities, consumers, as well as the acute care. Our newsletter gets to every hospital in the United States, and it's also received in other countries outside the United States, including Canada and some of the provinces there. It really does result because the regulators listen and they learn from these events. And it results in changes in product nomenclature and labeling and packaging and device design and practice issues and development of standards and guidelines. And I'm going to show you that in a minute, how all this information has been so useful. And I think more and more, I just see the importance of these safe practice centers, these independent centers, or even establishing one on your own as a PV center, where you interact directly with the field. They want to tell you about these problems. They want you to learn. They don't want a patient to be hurt. It's done out of altruism, and they will spend a lot of time with you, as they do with us on the telephone, interacting with us to teach us something, to tell us and help us understand the problem. They send us photographs. They send us screenshots from the computer. It's really a wonderful, wonderful system, and it's very, very inexpensive. And so I wanted to talk to you a little bit more about that and share some of the successes, because there have been a tremendous number, in the thousands over the years since this program started. And it isn't just in the United States. As I said, there are other countries that have had similar experiences. We receive information from consumers from the Medication Error Reporting Program, from practitioners. We also receive the reports that come to our Medication Error Reporting Program, and we have a Vaccine Error Reporting Program. We also have a memorandum of understanding with the Food and Drug Administration, and they are able to share reports upon request with us. And then, of course, if we learn about something in the media, or through maybe there's a journal article that we've seen, an anecdotal report, we try to learn from that too, and we may put that in our newsletters. It goes through ISMP, and then it goes out to our practitioners through the newsletters, to healthcare organizations, to consumers, to regulatory, and to industry. So we really work with everyone. When an error happens and it's a product-related error, we call the company. We make sure that they see these reports. We send them to the regulatory departments. If it's serious, we have phone conversations with them and try to make recommendations. And that work is done pro bono. We do not charge for anything like that. In fact, all of our work with our FDA and the IMSN, we do on a pro bono, on a free basis. This is our memorandum of understanding with our FDA. You can find that on the FDA website. It's a legal document. It is with the Center for Drug Evaluation and Research. And both myself and Dr. Woodcock, who heads that in the United States, have signed that. We have a great relationship. We basically talk every day. I already interacted with them over some problems we're having today with enoxaparin syringes and failures in the system and the needle protection system. I interacted with them about that this morning. FDA publishes in our newsletters, the advisor publication. We just published one last week in our newsletter. And also, we share a fellowship program. FDA funds a fellowship program for ISMP. So we have an FDA fellow all the time, year after year. And many of the guidance statements that you will find on their website, and I'll show you pictures of them in a minute, really started in large part from our reports that came through the program and were shared with them. Basically, we receive the report, we investigate, we inform, and we prevent. It's really been a key to success. And I can't tell you how important this program has been to patient safety. It is always handled confidentially. We have never identified an individual or an organization in all the years since we started in the 70s. So that's important to know. Report is received. Our professional staff reviews them. We share the information together. The report is identified as requiring further info. We do that work. If additional resources are needed, we apply them. We come up with realistic recommendations. Some of them are evidence-based. Many of them are just collaboratively developed by experts and our peer review mechanism. Some of them are obvious. So we'll talk about that perhaps a little bit later. Hazard errors, stories, and recommendations are then shared. This is not a gigantic database that we're sharing data. We are sharing stories, anecdotal reports. That has a great effect at nurses that read this and understand what happened to one of their colleagues around the country and what they can do to prevent that. It doesn't always work, but in large part it does. And then sharing it with the regulators and the standards and the accreditors just makes it come to a much higher level. Aggregate data from our databases is also published, like our vaccine R reports. So this is an example, and you can find these on the FDA website. Safety considerations for product design, meaning labeling and packaging. A lot of this came right out of the program. This is a standard from the United States Pharmacopoeia, largely from the program. One of the recent ones we did in the US, we eliminated the ratio expression for many drugs like epinephrine, isoproterenol. There's no 1 to 1,000, 1 to 10,000. Neostigmine, none of those have the ratio. It's only metric system now. The ratio was causing confusion and dosing errors. And so USP decided to eliminate it. They changed the way that we express the concentration on labels. This was done several years ago. These are exactly the same amount of heparin in each container. On the left, it looks like it has 10,000, but if you look carefully, it's a 4 milliliter vial. On the right, and the way that all injectables are labeled now in the United States, it's the total amount per container, and then the amount per milliliter immediately following. So that's something that came. And other countries around the world have, like I said, folks in Colombia and in South America, one of the leading problems of drug mix-ups is the way hospitals in particular use ampules. And many of the ampules do not have a background where the label is. And so it becomes very difficult. On the top left, these are all different drugs. They certainly look the same. So you can imagine how a nurse could perhaps return something to stock and put it in the wrong bin. And on the outside of the bin, it says what the drug is. And the next person that goes there goes by the label on the outside of the bin, not what's actually on the label. One of the companies, I don't mean to promote any company, but they did a great job in taking all these ampules that you see and putting a background on it and making it so that you can handle it in the right hand and hold it in the thumb and forefinger and read the label rather than making it upside down. This is just examples and examples of things that can be done with a very inexpensive practitioner reporting program that will give you input. Are we making progress? Well, I would tell you we have made fantastic progress. I think with many of the actions that have been taken through USP and FDA, we've affected thousands of medical product issues. And with work that we've done with the accreditors and with USP, again, many things, practice-related changes. Like I told you, KCL no longer allowed on nursing units. Abbreviations like U for units and several others no longer allowed if a surveyor comes in and interacts with the hospital and sees that in the records, they probably would say something. And so everybody strives to address the many things that Joint Commission and others like our government agencies and other accreditors in the United States. So it really has, addressed system issues, not people issues. We really stay away from, implicating individuals for not doing the job right. We instead look at what set the person up to make the error. That's our focus. And sure, there are situations where, somebody didn't do what they were supposed to do, but we want to know why. And there's certainly, incompetence. That's certainly a possibility, but we're very careful about that. We don't use that in our writings. We're always looking at what could be done with the change in the system, whether it's practice or product. The accreditation standards I've talked about. We also did something I thought that was very valuable. We came up with a list of what we call high alert drugs. These are drugs that, They may not be involved in more ERVs than other drugs in general, but when they are involved in ERVs, they're very likely to harm a patient. And so we did do a study, and we do have a published study on high alert drugs from the 1990s. That's where we started this list, and it has really played out. Others have come up with the same drugs that we have. Insulin, the top of the list, was 11% in the 1990 study. And we have seen other authors come up with very, very similar figures. Opioids, neuromuscular blockers, and so on and so forth. So we focus on high alert drugs. We even have an assessment for high alert drugs on our website. This is something else we've done. We looked at practice-related issues, and we've developed a list, and it is available internationally now. We have 4 for international use on the International Medication Safety Network website. IMSN website has 4, the latest being 2-component vaccine errors. We actually just published something in Uppsala reports. We had over 85 deaths in the Western Pacific due to an initial medication error with the vaccine errors, where with measles vaccine, where it was reconstituted with a paralyzing agent. It's the second time we know of that this happened. Another case was in Syria with 15 children that were killed. Those were 2 children that died, but then those opposed to vaccination use, unfortunately, promoted not getting your child vaccinated. And all of a sudden we had a measles outbreak, and over 85 children, not just all children, almost all of them were children under 5, died from measles. It's a horrible story. It's on the Uppsala Reports this month issue. So we hope you're looking at that. We do have these targeted medication safety best practices, and I certainly don't have time to go over all of them, but here you are, and you will find them on our website. We don't want anybody drawing vincristine up in a syringe. We don't want anybody giving methotrexate orally for rheumatoid arthritis or a non-oncologic use. That's in the new labeling for FDA as well. It's weekly, period. Weekly, not daily. And I could go on, but again, I don't have time. But all these have in-depth coverage on our website. If you type in on the ismp.org website, targeted medication safety best practices. This is a project that we did with regulators from around the world. Many of them participated. We invited them to Washington, DC to meet on the FDA campus. We had all of these that participated, that came, and we developed a list of recommendations for labeling from around the world for regulators to follow. All these regulators agreed to these, like don't use U for units, or IU for international because it looks like intravenous. And we've had oils injected intravenously. Again, you will find these on the website. So the contrasting background for the labeling, as I was showing on the ampules, is another one. We really started pushing for ready-to-use pre-mixed solutions, pre-filled syringes. There's also a lot of work that was done on preventing drug name mix-ups. There's guidance for industry. We've experimented with tall man letters, like you see there with the hydroxyzine. That's mixed up with hydralazine. It's a very common error. We have a big error problem with metronidazole and metformin, so we started using tall man letters there. We do need a study to prove that this is effective. We do not have that. This is, probably could be done in a better way with bolding and color and so on and so forth, like you see on that hydroxyzine level. More on developing names from FDA. This is just a good example of one of the many, many name reports. Durezol, I believe, is a ophthalmic steroid, and Durasal is salicylic acid for warts. So Durezol and Durasal, they certainly sound alike. We had to get one of these to change their name. FDA really pushed for that. So that's the kind of thing they do. Fortunately, we are at a point where we're pretty much electronic. That has not ended problems. We certainly have improved with the handwriting issue, but we have a serious problem where people call up a drug name by using the first 2 or 3 letter characters and get several different drugs whose names look alike on the screen at the same time. Then we have somebody choose it incorrectly. So that's something that we hope to provide more research on how it happens. and what can be done to prevent that. And there already is some research being done in this field that we are aware of from Illinois. Lots of good news with safety technologies. We're very fortunate to use barcoding. We use a national drug code here. I know that's not used outside the United States. You have the drug identification number. I think in the near future, we're going to see more and more. I saw one company already has radio frequency ID for some of their products. I think there's a way probably that we would even be able to use the same numbering system or our own numbering systems, but use RFID to identify the product. That would go a long way to helping us work together and even import drugs from one another's countries, make more generic drugs available to lower prices, et cetera. We use a lot of infusion pump software, drug libraries. That has saved lives. There's some evidence behind that. We are integrating the software now with our electronic health records so that when the doctor prescribes, or nurse practitioner prescribes, or PA, physician assistant, they get immediate recognition if they prescribe too high a rate or the wrong concentration for that patient. It's amazing. We have hundreds of hospitals that have done this. Otherwise, the nurses get these messages when they program the pump, and they have to use barcoding. They barcode the patient, they barcode their own ID, and they barcode the module on the pump, and that calls the drug up on the screen. It's already been screened by the physician if they prescribed it that way. Otherwise, the nurse gets the alert. Same with dispensing cabinets. We have a lot going on with electronic technology to improve safety there. We have workflow systems where we have learned from European countries that use similar systems where they weigh the final product or even individual products to make sure they have the right amount of drug. It is very sensitive, down to microgram. So these are all important ways to prevent errors, and we've made great advances in sterile compounding. I'm going to bypass this slide right now to save time. I mentioned we really push for pre-filled syringes. We have no idea what happens on nursing units where the poor nurses are so harried with the work of a COVID patient and interruptions and noise and having to take care of so much work at the same time. And then we also make them compound IV medicines. And sometimes they get labeled and sometimes they don't. Sometimes they get mixed up and sometimes they don't. I think our manufacturers can provide a way around that with the pre-mixed containers and the pre-filled syringes. And we have really used that a lot in the US and in some other countries as well. So I think that's a very important way to prevent errors, and we hope the use grows. Many guidelines on our website. We hope that you will take a look. We have a list of abbreviations that shouldn't be used, lookalike drug names. These are all, based on US drugs, but other countries have done the same thing. And by the way, we are happy to interact with anybody by just getting in touch with us, ismpinfo@ismp.org. These are other guidelines that we've published that are all based on information that we've gotten from the field, our reports, and then interacting with our reviewers, with our volunteers out there that are willing to help us put these documents together. We're now using a standard called 80369 from the International Standards Organization to prevent catheter mix-ups. We have two now. One is NFIT for enteral mix-ups. For IV, accidentally giving something IV that should go via the enteral route, a tube feeding, for example, and then NRFIT, which is for neuraxial, so that we don't make that mistake. So these are available. These are out there now, and we promote these. I did want to let you know we have a Medication Safety Officer Society. That's very important. These are people that focus on nothing but medication errors. We're up to about 2,500 members right now, and these are employed in hospitals. I know at the NHS, we are often on their monthly phone calls. I think they have one even coming up today. They have medication safety officers, and some other countries do as well. Their total focus is to eat, live, and breathe medication safety. We do have patient education materials, so I wanted to let you know about that. They are on our website. It's actually a checklist. So this one is for transdermal fentanyl, and the pharmacist can go over each of these medication or potentials by going through this checklist with the patient at the pharmacy counter. And then our websites. We have a consumer website and the Medication Safety Officer Society, and on the left, our acute care website, ismp.org. And then the IMSN, the International Medication Safety Network. I'm unfortunately running out of time. I do think, I've talked about some of these, where else I think we need to focus our attention. I really push for the, nurses to not have to prepare their own doses, to use premix. I think barcode scanning, we've got to find a way. Many countries import drugs from multiple countries. And, they have the US barcode on some products. They have the, maybe you don't even have a barcode on a lot of the products. So they have to put their own on if they're going to use bedside scanning. I know that is done in the Middle East, for example. We need to do better than that. We need to come together to figure out a way to get a standard system for barcoding so that places that don't have their own industry throughout the world can import and have a single way to employ barcoding. That is a phenomenal way to prevent wrong doses, wrong meds from getting to the patient. And then adhering to guidelines established by global regulators. I really believe in doing what I've been talking about, in creating an independent, voluntary practitioner organization to work locally with the providers. It could be done by region. And I think you would get tremendous cooperation as long as you made it clear that you're not going to identify them, that it is for learning purposes, that it would be shared and never identified, that it is not punitive in any way whatsoever, and that you have a way, to be trusted, to be able to do this work. Increased cooperation between manufacturers and reporting programs, and then mandated patient education programs. And I will stop with that. And I thank you again, ISOP, International Society of Pharmacovigilance, for inviting us to participate in this program. Thank you very much. And I'll take questions now.
Dr. Cohen, thank you very much for your presentation. And so let's open the floor for questions. Our first question, has there been, so in your presentation, you actually mentioned a lot of different approaches and principles that we can utilize to reduce medication errors. Has there been a systemic study to evaluate the effectiveness of different approaches?
Well, yes, in some cases there have been studies. For example, one of the recommendations we make is an independent double check, where if somebody does a calculation, we have a second person come in and do a calculation. That's one example of an independent double check, and they both have to come up with the same answer independently. So there are studies showing that can be an effective way. A lot of it, we make things impossible. If you don't have a potassium chloride concentrate on the nursing unit and you only have the bags, or pharmacy mixes them for you, you can't have that error where it gets mixed up. Some are just obvious. The vincristine example that I used, you can't inject, I shouldn't say you can't, but it's out of 140 cases, everyone has been a syringe. And about 80% in the United States now use a mini bag, 85%, we've studied that. You don't inject a mini bag of fluid into the intrathecal space. Color differentiation would be another one that is obvious when you have two containers that look alike and they're both blue and you make one red and one blue. We do look at the human factors literature. We do, RFID and barcodes is another one that's been studied. But many of them are developed through collaborative agreement by experts. And I'm talking about the standards, for example, in USP's Chapter 7, that, there's a committee called the Nomenclature and Labeling Committee that has worked over the years to look at medication errors and figure out how to prevent them. Not all are 100% effective, but they're a step above what we were doing before. So there isn't just one way that we come up with to prevent errors. It's not just system analysis, system studies, I should say.
Thank you. Our next question is, so in your presentation, so you mentioned a lot of stakeholders and require their collaboration to improve the patient safety and reduce medication errors. So this question is more focused on the patient education. So patient education plays a very important role in the medication safety. So can you talk about various approaches that have been taken and to make the education more accessible?
Yes, yeah, that is a really important question. And I don't know that we always do the best job. We've had errors that happen, for example, with insulin pens, where we've never had a diabetic educator talk to the patient, yet there's been a prescription for a pen. And we've published many errors that we've heard about from consumers where they don't know how to properly dial the dose. That could have been avoided with education from a certified diabetic educator, or at the pharmacy counter when the insulin pens were dispensed. But unfortunately, that never took place. We like the idea of teach back, where you work with the patient and show them and let them show you what they're going to do. I should mention we have, and I showed very briefly, a consumer website. The address is consumermedsafety.org, and it has an insulin safety center where we, just like we do for healthcare practitioners, we have all of the errors that we've gotten from consumers and healthcare professionals that we think consumers need to know about to protect themselves when they're in the home. There's a lot of reports there, things that you wouldn't think of. We also have a section on over-the-counter drug safety. You know, how to choose an item that's an over-the-counter drug. We've had mistakes happen or misuse happen, and so we have a section there that's very valuable for consumers. I think simplifying things, we've tried to simplify things. You know, in the United States, believe it or not, we've had problems with measuring devices that instead of just using the metric system, we've used fluid drams, the old apothecary measure. We've used ounces. We've still seen, you know, other household measures, teaspoon, TSP, tablespoon, TBSP, where they get mixed up and somebody gets a tablespoon instead of a teaspoon. So again, our role has been to learn from the consumers and the healthcare practitioners, publish this in our newsletter, work with the federal government and with the standards organization, work internationally to bring some of this information out there. And then, you know, hopefully people will be able to use that information in teaching patients. A lot of it also could be prevented with telephone calls, follow-up telephone calls when a patient is discharged. So you ask them how things are going. And not all drugs lend themselves to this. The labeling, you know, how we express information on a label, that has been looked up. There are studies that show the best way to write one tablet 3 times a day. It may not be what you're familiar with. And so, yes, there has been a lot of work done in that area. And I do think we could certainly improve. Our biggest problem in the United States, we have a lot of these chain pharmacies and the staffing may not be what it needs to be. So the pharmacist is not readily available to the consumer. And oftentimes they don't get that face-to-face education. So we try to teach the consumers, never leave the pharmacy without talking to the pharmacist. And by the way, I'll just end with this. The #1 error that we get, leaving the pharmacy with someone else's medication in your bag. We did a peer-reviewed study. It was published in American Pharmacist Journal a few years back. We were able to reduce the number of cases by 50, 60, 70% by 2 identifiers for the patient, their name and their address, for example, or their birth date, and just telling the consumer, open up the bag before you leave the pharmacy and look at the container label. Bingo. That was all we needed to do. So there is a lot of literature out there, and we have subscribed to some of the evidence-based literature. And then, you know, it's not just that, though. You can't improve patient safety without, you know, using expertise that's out there, without looking at things that are obvious that need to be done. And I'll stop with that.
Thank you. We have another question here. I think it goes, this one is focused on the National Regulatory Authority. So how can we engage National Regulatory Authority to allow harmonization of safety labeling standards?
Yeah, so what we did, I kind of touched on this, but because of time, I didn't have enough time to go into it in depth. We work very closely with our Food and Drug Administration. Lubna Merchant is the person that represents FDA on the International Medication Safety Network. All of our IMSN members, and we invited regulators from around the world to come to Washington, where we looked at all kinds of labeling and packaging medication errors. We developed a white paper. I kind of listed the bullets from that. There were 10 items, and that was presented last December to the International Council on Harmonization. And I know that they've done some work already to put that information out there to some of the industry and also some of the regulators that perhaps weren't in attendance. But everyone agreed to these. And we certainly hope that many of them are acceptable, if not all, to manufacturers, because a lot of them would go a long way to preventing many of the medication errors that we see, including those that we talked about, like the heparin error or the U4 units or whatever. So that's an answer, I think. And that's, again, this is why we need the PV centers, the companies that have PV centers, the companies that don't have PV centers or use outside expertise, the regulators, the accreditors, the people that are willing to report and tell you their story for nothing more than, you know, having that information accepted and acted upon. That's all they care about. They would love to read about you, you know, having a victory sooner or later. And it can't be done for profit. That's the other thing. So we have other ways of, you know, getting funding for this. That's it.
Thank you, Dr. Cohen. So here's another question, more specific to the time we're in right now. So in COVID pandemics, what are the important problems that you consider is relevant to medication safety?
Actually, we put out a press release today, or I should say our affiliate ECRI put out a press release today. And what we've done is we did collect a lot of medication related errors during COVID, especially in the early months from March until June. We've continued to get reports now and then. They're available for free on our website, and ECRI has them on their website, and it was in the press release that they sent out this morning in honor of World Patient Safety Day. But if you go to our website and look for COVID, or if you go to the ECRI website, they have a whole safety center with a number of full newsletter articles that we did or that they did that address all kinds of things, from personal protective equipment use to drug errors with or adverse reactions with hydroxyzine to use of infusion pumps out in the hallway, which was, it turned out to be a great idea to reduce the PPE that we needed to change every day. And also to reduce exposures of the nurses going into the patient room. But we ran into some medication error problems. How do you scan the patient's wristband if you're changing the bag outside in the hallway with extension sets leading to the patient? So all those are in there with photographs. There's some live or some recorded events that we did on webinars. Please take the time to look through that material if you have an interest. Thank you.
Thank you, Dr. Cohen, and also thank you everyone in the audience and for your participation.